we're going to talk about thyroid cancer. If you have not seen my presentation on nodules, I suggest you watch that prior. As a general overview, thyroid cancer is going to be lumped into 4 general types. There's a lot of different kinds, but they are lumped into these main categories that include papillary thyroid carcinoma, PTC, follicular, medullary, and anaplastic carcinoma. And subcategories of the different types of cancer may be classified as well differentiated, poorly differentiated, and undifferentiated. Okay, and these generally present as asymptomatic nodules. This is why looking at thyroid nodules is super important, so we can try to pick up on cancer and nip it in the bud, right? In general, the treatment surgical. And then prognosis is, again, it's good if we find it early. In terms of incidence, not completely unheard of. Around 14.5 per 100,000 people per year in the United States are diagnosed with thyroid cancer. And it predominantly has a female sex preference, especially over 40 years old. Our lifetime risk is 1.2%, and it's usually spontaneous, more so than hereditary. Radiation exposure likely has a role, and there are some genetic mutations and inherited conditions that have been established. As far as risk factors go, again, there are a few hereditary factors identified, and so if a first-degree relative has this, you're going to want to be especially careful in your physical exam to pick up any nodules. Radiation exposure in particularly puts people at risk for papillary carcinoma. Iodine deficiency places one at risk for follicular carcinoma in particular. And as far as inheritance goes, there's the MEN2 gene. It's the RET proto-oncogene mutation, puts people at risk for medullary carcinoma, and this is autosomal dominant. So if that is in the family, you will be maybe even doing a preventative thyroidectomy, okay? I think this term has been more in the news lately. You probably hear of this more commonly because of it's on all the Ozempic commercials, right? Contraindicated in people with MEN2 medullary carcinoma. That's probably why it sounds more familiar. So just throwing that out there. People with a previous history of malignancy, perhaps they've had a subtotal thyroidectomy, puts them at risk for anaplastic carcinoma. So that's basically recurrence with a vengeance. Hashimoto's thyroiditis places people at risk for papillary carcinoma, and we talk about that in our thyroiditis videos. So papillary carcinoma, Hashimoto's. Patient has Hashimoto's, you're watching out for carcinoma. There's a fairly high risk, okay? Medullary carcinoma, some associated probable risk factors include pheochromocytoma, hyperparathyroidism, and Hirschsprung's disease. So first and foremost, signs and symptoms, we always talk about a history, okay? There may be no signs or symptoms, but we have a good history, and we need to know if there's a family history of, positive family history of thyroid cancer or a known genetic risk, okay? And also, did they have radiation exposure, whether this is environmental or were they previously treated with radiation therapy for cancer in childhood or adulthood? Serious symptoms or signs on physical exam is going to be a change in voice. Dysphonia is a huge red flag, okay? If they have dysphagia, difficulty breathing, dyspnea, or stridor may be a presenting symptom. All of a sudden they're having respiratory distress, and it's actually a mass that's invading the that's invasive and maybe even affecting the vocal cords. A growing neck mass is always a concern, especially in non-mobile mass, okay? A nodule, benign nodule, is usually going to be mobile. If it is firm and non-mobile, very suspicious for malignancy, okay? And associated lymphadenopathy is also very concerning for advanced malignancy. Diagnosis, we're going to start with our initial labs and imaging. This is very similar to our nodule workup. So we may start with an ultrasound to define this nodule, and then draw a TSH, which is usually going to be normal at malignancy. But again, we first get a TSH to define nodules as hot or cold, right? Then, depending on their presentation and history, we may proceed with a CT or an MRI of the neck. We are going to do some MTC, so calcitonin levels, okay, and then a thyroid scan, again, to determine if this is a hot or cold nodule. Procedures include FNA if they are high risk disease, or they've got they present actually with dysphonia. Probably going to send them off to ENT to get a flex laryngoscope procedure done to take a look, see what's going on. And then always keep our differential diagnosis in the back of our minds, right? This could be a multinodular goiter, thyroid adenoma. Is this a thyroglossal duct or simple dermoid cyst, thyroiditis, a thyroid cyst or nodule, simple, or is this ectopic thyroid? So for the remaining of this presentation, I'm going to go a little bit of a different route and break the treatment plans down by the type of carcinoma, okay? So we'll start with papillary thyroid carcinoma because this is the most common. You will see this again. The most common thyroid cancer is papillary thyroid carcinoma, PTC. This is up to 80% of thyroid cancers, okay? This is considered to be a differentiated carcinoma, and its peak incidence is in the third or fourth decade of life. And radiation exposure places people at very high risk, and this tends to metastasize by lymph nodes, okay? Unfortunately, up to 30% of these people already have palpable lymphadenopathy at diagnosis. But if they are under 55 years of age without distal metastases, there's really excellent prognosis for this. So if this mass, or I would consider it a mass over 4 centimeters, they are going to immediately get a total thyroidectomy followed by radioiodine ablation of any residuals. So we are knocking the entire thyroid out, okay? Then we are going to have lifelong suppression with levothyroxine to minimize regrowth of that gland, okay? We're going to monitor our thyroglobulin levels and screen with ultrasound for nodal recurrence after, that's a subsequent treatment, okay? Now, if these are small, this is a small, less than 4 centimeter encapsulated carcinoma, they can still undergo thyroidectomy, but it could be a near total, so you can save some of this thyroid, or they may just do a lobectomy. This is a conversation the patient will have with their surgeon. I personally would probably just not take any chances and have a total thyroidectomy, but individual choices. But this is curative. And then, of course, they'll have subsequent TSH suppression lifelong with levothyroxine. If this is a very small nodule without any evidence of lymph node or distant mets, there is an option for active surveillance, and you may want to think about an elderly person or somebody who's just not a good surgical candidate. So let's talk about follicular carcinoma. So this is our second most prevalent variety of our thyroid cancers, up to 20%, and of thyroid tumors, and this is also considered a differentiated carcinoma. So the peak incidence is going to be a population a little bit older. This is in your 5th decade, and the biggest risk for this is iodine deficiency. Now, follicular carcinoma metastasizes via the blood, and we can further differentiate this type of carcinoma into invasive or minimally invasive forms. Okay, so our treatment is going to be similar to our papillary carcinoma, where we want to proceed with a near total thyroidectomy with postoperative radioiodine ablation of any residual thyroid tissue. And I put that twice, so I must have really meant to hone that in there. And then we'll proceed with TSH suppression with our levothyroxine. We want to minimize regrowth there. I apologize for the background noise. I live in the city. So we want to continue to monitor our post-treatment patient with thyroglobulin levels and ultrasounds of the neck to screen for recurrence as well. In terms of medullary thyroid carcinoma, MTC abbreviated, this is going to be less common. It's only up to 4% of all thyroid carcinoma. Okay, this is actually a neuroendocrine tumor, and it produces calcitonin. So think MTC, men, because many of these people will have a familial multiple endocrine neoplasia syndrome, inherited, okay, men syndrome, and then TC, calcitonin, okay? So our risks are going to be the family history of men, that mutation, pheochromocytoma, and hyperparathyroidism, okay? So again, up to 35% of these people with this more rare thyroid carcinoma are going to be associated with the mutation of that RET proto-oncogene. Again, this is that men syndrome that is a contraindication to using Ozempic and some of those other modern weight loss tools that were originally used for diabetes. So keep that in consideration when you're treating your patients with diabetes. There are variants of men syndromes, and they are the variants are very specific to childhood, young adults, and then middle age. This type of carcinoma metastasizes through the lymph nodes as well, and it tends to adhere to the liver, lungs, and bone. Again, they may present as a nodule, or you might find a nodule while screening this patient because they have they're known carrier of the MEN mutation. We are actually going to diagnose this via high calcitonin levels. Okay, this is the best serologic marker, and we were going to use this for a basal plus stimulated levels. Okay, so anybody who has high calcitonin, they have medullary thyroid carcinoma, we want to do genetic testing. Why? If they have the RET, the RET proto-oncogene, that can affect other family members, and so we want to then proceed to screening all family members so we can, knowledge is power, and knowledge is cure, and prevention is cure. So if we can prevent other family members who may even consider an early prophylactic thyroidectomy if they're a carrier. So that is one of the treatments, okay? Long-term survival is actually very common in patients with medullary carcinoma associated with MEN2A, that subtype. And so most of these patients, they can stay alive for 10 more years. The other types of the MEN, which is 2B, it's a sporadic type, have a poorer prognosis. So I'm going to stress again, the treatment for this is going to be total thyroidectomy. And then the extra step is going to be lymph node dissection. So we're removing the thyroid if we find this because it's aggressive, and all the surrounding lymph nodes. Okay. Most likely you're going to have a the parathyroids will be removed, particularly if they're hyperparathyroid or hyperplastic or boggy or, edematous. So that's going to be pretty common. And then they'll have, of course, lifelong hormone replacement. Again, relatives can consider prophylactic surgery because it is up to a 35% chance of having cancer with those genes. Again, prognosis may vary based on the subtype, like I said, and about 2/3 of these people will be alive at 10 years. But again, it's a very aggressive form of cancer. Anaplastic carcinoma, this is actually poorly differentiated. It's very low percentage of thyroid tumors considered in the undifferentiated category. And our risk for this is going to be pre-existing or prior differentiated forms of thyroid cancer. That's your papillary and your follicular types, okay? It can be spontaneous, but our risks are going to be elderly patients who had a remote history of thyroid cancer that was thought to be curative. There are actually no treatments, unfortunately, for this. I consider this basically a recurrence of cancer. Unfortunately, there are experimental treatments out there. There are targeted treatments that may slow the progression, but there's no difference in long-term survival. So perhaps may slow progression and the morbidity aspect, but this is still going to be deadly because it is the most aggressive form of thyroid cancer, and the median survival is 2 to 6 months, unfortunately. On that note, I have the happy face because we're done talking about thyroid cancer. So I hope you all have a good day. Here are my references. Take care.